An interesting study has found that children from high-income families are exposed to 30 million more words than children from low-income families during the first 4 years of their life. So why do we think this is an issue? If we think at cognitive development and school readiness, we do know that when people come from low-income families, perhaps, and they had less exposure to words or a variety of words, they could have a disadvantage when they start school. And so when we're talking about low-income families, we really have to keep it simple. I think we talked about low literacy when we were talking about nutrition education. And this is very important, that when we are talking about this, nutritionists will have to build the nutrition education programs based on not only the linguistic, on their cultural habits, but also on their on what their literacy levels are. And I think we have used this before, and we said that the use of pictorial graphics and such as My Plate, or even illustrations of foods, should also be used when we communicate nutrition messages to people, and especially in the cultural aspect, to also include the use and the illustrations of traditional foods that people are used to eating. So that is very important. And also when we're talking about this literacy again, we should also not assume that all our clients are able to read in English or even in their native tongue, because we have to make sure that they understand the basic nutrition and health information, food labels, food preparations, dietary plans, all those things. We have to sometimes translate into their own languages if we want them to do. So the need for cultural competence is really very important. Like I mentioned earlier, that at the moment there is still underrepresentation of the diverse healthcare providers, but in future there is a lot of legislative, regulatory and accreditation mandates that are now really addressing this in the country, so that we cannot exclude the different cultures when people are being appointed. And we have to have cultural competence so that we can also work with all these different people, not only as patients, but also our colleagues. So if we look also even at Healthy People 2020 goals, they already tried to address this disparity and cultural issues in the Healthy People 2020 goals, because the first one was really to attain high quality, longer lives free of preventable disease, disability, injury and premature health. There was also the health equity, to eliminate disparities and improve the health of all groups. And the very last one was also to improve the linguistic and cultural competency of public health professionals. And that is why we are also talking about cultural competence in this class. Cultural competence, if we again just look at the definition, is really defined as the understanding of the importance of social and cultural influences on individuals' health beliefs and behaviors, and that we have to really consider how these factors interact at multiple levels of the healthcare delivery system. And when we also design our interventions that you are going to do in your assignment 3, we have to take these issues into consideration. It is not only when we are working with our people, it is also the ability to work effectively with individuals from different cultural backgrounds and ethnic backgrounds. And what we need to really understand is that this requires a continuous developmental process that involves from us as healthcare workers a long-term commitment and a significant effort in acquiring the skills, the practices, the attitudes towards becoming culturally competent. So we have to sometimes do quite a lot of things to try and understand what other people, our colleagues and our patients or our communities, how they do things. And we have to also integrate this knowledge in our daily practice, but these also take a lot of time. When we look at this, I'm not going to go into detail here, but when we look at this figure, it it really says what are all the health disparities that are there at the moment, and how the food and nutritionists can really get involved into addressing all these different health disparities. So if we just look at the one at the bottom, the lack of healthy and affordable foods for purchase in stores or through food service venues, that is also one of the factors that are contributing to health disparities. And food and nutrition practitioners who work in the food industry and food service organizations can influence the types of foods the public can purchase in grocery stores. Also, we can influence labeling, also the types of meals that people can access in the food service arena. And we can also partner to advocate for policies to improve access to healthy foods. And a good example of this is the school nutrition lunch program and the breakfast program, where they have now addressed this by adding healthier food items onto the menu. So we can play a role in how to really overcome these health disparities that we have. So we really need to, like I've said already, need to communicate across cultures, and we also have to develop so that we can get the skills in order to communicate, not only communicate with people, but also to give them the necessary knowledge through nutrition education. But all of this takes a lot of practice, effort, and time. So there are some cultural competence models that we can apply to teach us these skills and to tell us how we can gain these cultural competency. And the first one that we are talking of is the cross-cultural competence continuum model. And I'm not going to go into too much detail in this, but this really means that movement through stages, there are certain stages, and that this is a process that will, where you will move through stages from destructiveness to incapacity to blindness to pre-competence, competence, and eventually being proficient in dealing with a specific culture. So this is also a model where we can measure and evaluate our own cultural competence. But what is important to note is that we can be culturally competent to deal with one specific cultural group, but that does not mean that we are culturally competent to meet with different or a number of culturally different or cultural groups. So we have to constantly see who are our patients, who are our communities in which we are working, what are the cultures that they are having, and we will have to almost have a lifelong learning process in how to get to know what the culture in that specific community is and with these specific patients, so that we can be competent to work with them. So here are the constructs of this specific model, and this is basically the cultural destructiveness. This is where we have absolutely no idea that there is a difference in culture, and our attitudes and our practices can be destructive to other cultures. The next one is when we have incapacity, where we are having like a paternalistic attitude towards what we call the unfortunates, people that do not form part of our culture. And like I said, that ethnocentric behavior can basically come in here, because we at this level we have no capacity to help other cultural groups, because we believe that only our culture has the wrong, or our culture is right. Also cultural blindness, when people believe that their culture makes no difference and that everybody should be treated the same. So we have already said that when we are talking about community nutrition, we really need to do a needs assessment, because one size does not fit all. And when we are culturally blind, we do think that our approach will fit everybody's needs and everybody's culture. And this is really where we should not be. Cultural competence is really where we realize our weaknesses when serving culturally diverse populations, and we start making some attempts to make accommodations. Cultural competence is really where we have accepted and respected that there are differences, and that we constantly and continuously evaluate ourselves to make sure that we have got the cultural skills that are required, and we keep on adjusting so that we can serve our diverse populations better. And then when we get to cultural proficiency, that is when we can really engage in activities that can add to the knowledge base. We can develop new approaches, we can publish, and we can really feel confident that when we work with these different diverse communities, that we understand them and they understand us. So the next is also a different cultural competence for healthcare professionals, the Campina-Bacote model that was specifically developed, and they have 5 constructs on how to become culturally competent. And this is again a process that a healthcare provider has to work through within the cultural context of a specific client or a specific group in a community. So those constructs are awareness, skill, knowledge, encounters, and desires, and we will go and work through each one of them. So